contraindications, as you can imagine. I'm not gonna hold you to those. Obviously, if there's some issues with hypertension and uncontrolled diabetes, those are the risk factors to begin with. We probably won't select that person as an appropriate candidate for that. This is important to know. I'm going to put this bold stuff in red. You're taking care of your patient following his transplant surgery. When you notify the surgeon. If you have low blood pressure, why are you worried about that? Correct. Correct. And then why are you worried about excessive diuresis? Isn't that a good thing? Why would you call a surgeon about that?
Urine output.
You don't want to dehydrate that new kidney, right? So yes, we want diuresis, but we don't want a lot more coming out than what's going in. So we want that new kidney to get good blood flow. We want that kidney to stay hydrated, right? So if you're given that criteria, look at your I&O totals that you're given to decide if that's excessive diuresis or not. So I could give you an intake of a certain amount, give you an output of a certain amount, and you can say, okay, that seems like a lot more out than in. You guys good with that? Those two criteria. Just keep in mind, I gotta have this kidney hydrated. I gotta have this new kidney with enough blood flow. And also just sort of a fun fact, the donor has more pain, guess it's not that fun fact, has more pain than the recipient. The living, if it's from a living donor, the patient's kidney should start functioning immediately. If it's from a deceased, it takes a couple weeks. There are types of rejection, as I think we've already covered, or you probably already covered. Hyperacute,
Oh, I thought that was a fart. I thought he was farting.
to begin with.
He was farting. I'm like, what was that?
Acute could be a couple weeks post-op, chronic could be over a period of time. Lots of complications as goes with other types of organs and things that we try to transplant. The blood vessels can't get the flow going correctly, it can be stenotic, indications of impaired perfusion. There are actually kidney transplant programs in different countries. And you'd say, I don't think I would probably ever do that.
Oh.
What if I offered you, if you donate your kidney, I'll give you enough money that you can pay for your kids' meals for the next year. So
How much money?
Can I do it? No.
How much? How much is it? I need numbers.
Are you doing it or not doing it? All right. And
I've looked up.
your kidney, your brother needs a new one. You giving it to him or not?
Maybe. If it's my favorite brother, maybe. It depends what brother.
Like him or not?
Yeah.
Your brother takes really good
I
care
have
of
3
himself.
brothers, so I gotta, it depends.
He doesn't smoke, he doesn't drink. No. Are you giving him your kidney or aren't you? You're still not. Yes, some of you are. Your brother's a heavy smoker.
For Christmas?
He drinks a lot, but he promises he'll quit all of that when he gets
uploaded.
I let it out because you're supposed to.
He's got 6 kids that are all little, and he's a single dad. I'll take care of it. I'll take care of it. Rehab, is everyone giving your kidney? No? Did anybody giving your brother his kidney? He's gonna quit all his bad habits. Okay, he gets your kidney.
He's probably not gonna quit.
How about your stepmom?
She's probably not gonna.
That makes reactions on that whole deal. How about your child? How about someone that's got a 50-50 chance of taking your kidney that you're gonna donate, and you have 6 kids at home? You're gonna donate anyways. Do I know you have 6 kids at home? What? No, but they seem like a good person. They do a lot of volunteer work. They're a volunteer firefighter. Pardon me? Okay. What was that?
It's crazy how much. Have you ever looked up how much your heart is worth? They're expensive.
They said you're good.
Your organs, they're expensive. You can probably.
I need my heart.
I know, but I'm just saying, like, organs are expensive. You know, there's a black market that sells organs.
That's terrible.
There's probably like kids go missing.
One is donating theirs. Wow, that's where you just went. That good feeling.
Who was that? I like her.
So lots of ethical stuff. that we go through when we go through those, exactly what you all just did. It's like, well, if it's this one, and what if you have two siblings that need kidneys? Because they inherited polycystic kidney disease. Which one's more critical about the same? They're twins.
Oh. Well, which one are they on?
Which one's your favorite?
Do they have bad habits? Do they drink? Smokers?
I have a brother who's diabetic and doesn't care and won't take care of it. I'm not giving him a kidney.
Yeah, no.
Because I know he's not going to take care of
That
it.
How
sucks.
successful are they? They both are successful. They both need kidneys.
That sucks.
Amy, we'll draw numbers. Well, let's draw numbers.
Wow. So as you can tell, sometimes you as a nurse get caught up in some of those conversations, right? And somebody's got personal feelings about those, that's first of all. And second of all, you've got sometimes mixed reactions with your family members and people making those. Right away I said, how about a stepmom? And most of you went like, oh, probably not. But if you get on great with your stepmom and your mom's deceased and your stepmom took good care of you all and you were low. So there's so many things that play into it, and especially when there's siblings and people that are having conversations. So your job as a nurse is to give them good education.
They're so good.
And try to support them, realize the risk factors that play into that. You know, it is sort of, even if you're yourself personally, we had a gentleman in town that he needed one, same kind of scenario as I gave you. Volunteer firefighter, young guy, nothing he did lifestyle-wise that
Is he
impacted
cute?
his kidney. He's got a bad set of cards and a couple of kids, and they put out this notice and said, anybody that would want, could possibly consider donating to him. I didn't really know him very well. I know his parents, I didn't know him. I'm like, yeah, I guess I'm gonna apply. Please don't pick me, please don't pick me. So, and I had a history of one kidney stone like 20 years ago. That was on a questionnaire, and I got an email back and said, you're out. So,
Kidney stones
there's
save
lots of
you.
things that kind of get that narrowed down. And unethical discussions, but sometimes you as a nurse are in the rooms when there's a lot of that goes on, and you have to kind of help figure out how to be supportive of them. Renal trauma, that's the hematoma that I was talking about earlier. Make sure that someone is aware of that, that's bleeding underneath the skin that's going on. Make sure that it's communicated, make sure you're monitoring how big that thing is getting. Like I said, I always take a Panadol around the perimeter, so I know how much is changing over a period of time. Lots of things that could be impacted by that. And treatment just depends on how much blood loss there is and lots of other situations. So probably the biggest thing from this section, which is a short section, is the whole piece about your patients you're taking care of him following his transplant surgery, when you need to call the surgeon. What criteria, what assessment findings you need to call the surgeon about. And that was the whole low blood pressure and the output way more than the intake. Okay, now we're gonna cover the urinary disorders. Oh my God, I just love this part.
You got to. We again, you've done this. That's me.
Take it for last. There you go.
I probably have berry cancer and cervical cancer, breast cancer, BPH, BPH.
You're on death's door right now.
Yeah, knee
And then my other
prosthetic
son,
cancer.
he doesn't
I have the whole
All
thing.
of it.
really used to.
All of it.
I said,
I don't
"I
even
didn't
have
do
a
my classes." I was.
prostate.
Most common pathogens we talked about during jeopardy is E. coli, just by proximity to the urinary tract.
Patience.
Always questioning why the patient's getting a catheter. Does the patient continue to need a catheter put in or not? UTI. You should not find very many of any of this in the urine, right? The higher the number, the more indications of infection in that urinary tract. Lots of things we can prescribe for those UTIs. Increase fluid, Stay away from things that are going to irritate your bladder. We'll go through more dietary considerations in a bit. Sometimes people say they take cranberry juice and cranberry tablets when they have a UTI. Studies right now show that that doesn't really do any good once you already have a UTI. However, research has shown that if you take that daily, if you're prone, sometimes that can help ward off UTIs. So the jury's still out on that. Urethritis, inflammation of the urethra. Most common cause in males is sexually transmitted infections.
I think.
Acute pyelonephritis is a kidney infection. Acute, as it says, it's a bacterial infection. Most common is E. coli, as we just
Oh no,
discussed.
it's Ricola.
Symptoms, typical of infection, fever, chills. We were talking about evaluating, palpating for costovertebral tenderness in clinicals on Monday. So I added this slide. We can't remember what that was. I think you guys said it was on some ATI. There you go. That's how to target your palpations to determine if they are possibly having kidney issues. Placing the palm of your hand over that angle. And the angle, as the word says, costo means ribs and vertebrae. So that's where the angle is, right there where the ribs meet the vertebrae. That's the angle they're talking about. It's palpating it there, putting your hand down and taking your fist and palpating like that. And you should not have tenderness if you do not have kidney issues. So if they have issues and have tenderness, that may indicate they have got pyelonephritis. Treatments, antibiotics, and so forth. If I'm going through these pretty quickly, I'm not going to spend a long time on them because there's other things that are more important than that. Although avoiding dysfunction by definition is just empty. Urine is a problem. Incontinence is not a normal part of aging. There's 3 different kinds. So like I said, I'm just not going to spend a long time on those because some of those are long. Teaching a patient how to do Kegels to strengthen your urinary muscle walls. We talked about that with uterine prolapse before. Pretend you're stopping your urine stream is how we teach patients to do that. We also have cone therapy, which we can strengthen your urinary muscles. That's like you holding up weights when you're working out in the gym. So we put a cone in place, hold it for so long at a time, twice a day, increase the length of time, increase the weight of the cone, and it strengthens the muscles. There's lots of devices you can place into there. And there's other suspension systems.
It looks like a.
Like I said, if I'm not spending a long time on it right now, I'm not going to spend time on it. Lots of meds, you know, if you have extended release or you're going to swallow it whole. Neurogenic bladder, we talked about some of the neurogenic issues in neuro. So I'm not going to spend time on that one either. But we will spend a little time on urolithiasis, which are kidney stones. Any of you had a kidney stone in your past?
No.
Nobody?
Not that I
How
knew.
was the pain?
It was horrendous. It
What'd
was
you
worse
say?
than, it was
Where
worse
was
than
the
having a
pain?
baby.
Worse than having a baby.
Where did you?
Absolutely. You think that little bitty stone,
Oh, yeah.
how can that cause so much pain? Yeah, I had one in the past. I was driven from where I was at to the hospital by a friend, and I said, you gotta turn right on red. No, I'm not allowed to. That sign said I'm not allowed to. I said, today you're allowed to.
No clock, no
I said,
stop.
get with it, and then later, registration, that's what I said. And I, why are you here? I said, I was ready to labor here. And I said that then, I was gonna go park myself right now. Like, wait! Not today. Not stopping today. Okay, what happens is the urine gets saturated, it builds up, and it forms a stone. The stones can be anywhere, usually severe pain, especially if you're making urine and you can't get it outflowed. Depends on where the stone is as to where the pain is, but usually the pain is severe, severe, severe. Because it's like you have urine in your bladder, and the next rest area, next place to stop on the interstate is not for another 120 miles. You're like, oh my gosh, and then it just gets worse and worse and worse. So it can have, because of the pain, the patient can have vomiting, severe colic pain is what we call that when it's back there in your kidney area. You can have blood in the urine, that stone's irritating the urinary tract. you have no production of urine, or very limited, that is a medical emergency. That term, when you have urine caught up in this system, that term is called hydronephrosis. So yes, you can expect to see that with your patient that comes in with a kidney stone, because that urine can't outflow. So hydro means water, nephrosis is in the kidneys. So hydronephrosis is a condition we call when you have urine that is retained and it can't outflow. Hydronephrosis is the name of that condition. Again, positive CVAT, which we just talked about pyelonephritis. The stones, if we catch them, if we see them, we can evaluate what the stones are made of. So there may be dietary recommendations based on what the stone is made of. Maybe say you need to limit your calcium because your stone we found out was made of calcium. And sometimes we don't even catch the stones, the urine, the patient urinates, voids them, and we don't get to evaluate them. And sometimes there's really no correlation, but they may be dietary considerations. You don't need to know this, but it's just fun facts. Depending on the size, how likely is it you're going to be able to just pee them out on your own without intervention?
I'm afraid you have hailstones. Hailstones.
I'm sorry. Pain relief. Usually we'll go for either NSAIDs or opioids. The pain that is worse than having a child, get the opioids on board. So treatment plan number one is to get that pain control. Another treatment plan is what we call medical expulsion therapy, which is kind of a new term. It's a combined recipe of giving you a medication to relax your smooth muscles. That medication was the same one we talked about with BPH, if you remember. Pain meds, drink plenty of fluids, strain your urine as you go home. We want to see if we can catch your urine and analyze it. And then if we don't know if you passed it or not, do a follow-up imaging. But that's called medical expulsion therapy. And the hopes to relax your urinary muscles enough that that stone just flows on through. If that doesn't work, we may have to go something to a little bit more invasive. Lithotripsy. Lith means stone. Urolithiasis, lithotripsy. That's like jackhammering your kidneys from the outside. So you lay on the table, literally, the shock waves externally are placed, and the hopes to break this stone down, in the hopes then you can pee it out on your own. Not invasive, but a little bit more aggressive than what we just talked about. Stents are always an option. If we can't get that stone to move through, we may have to open that vessel up, widen that, get your stone to flow through. We can always do a scope, putting a scope up in with the pincers, like we talked about with prostate surgery. Break your stone up, remove it as such through this tool or the device. Otomy means incision into. So we may need to put an incision actually into wherever the stone is and remove it with a tool again. So it all depends whether the stone is located there, we do this type of otomy, there, or if it's in the renal pelvis. Otomy means making an incision into, putting a device in, and removing it through that device. If you ever look up natural remedies for kidney stones, you're going to find lots and lots and lots of thoughts about what to drink, what to eat, what to not eat. So I'm not going to hold you to any of these because you can just be here forever.
I'm sorry, just one last time. I passed them. Difficulty with
So your patient has urine that's caught up, that's been produced, it cannot outflow. You can have permanent damage within 48 hours. If you have urine retained, that is not able to outflow out. So that's the situation with your patient. They decide to put a nephrostomy tube right into the kidney, drain it out through that tube. Your job as his nurse, keep him NPO, of course. The catheter is placed. Postoperatively, your job is to monitor for things that are in red, especially. What does decreased drainage tell us? Correct, that the catheter is not draining the urine. What about the drainage that's cloudy or foul smelling? Infection. What about the site that leaks blood or urine? A bleeding complication, absolutely. And what the patient has back pain, what is that telling us? Correct, inside, urine that's not getting drained, or stone or something like that. So those 4 criteria, which makes pretty good sense, is what you want to monitor for, notify the surgeon about. If the patient experiences any of them, when you're taking care of this patient that has just got an nephrostomy tube, that's got to put in place. And it isn't a caution sign, and it is in red, so that's important for you to know as a nurse. Dietary recommendations will depend upon what the stone is made of. So we'll have to see if it's a trend, if it's something that we can analyze, and maybe we need to suggest change in your diet. There's lots of little synopsises that if you want to, pull them up, or especially when you get ready to take your NCLEX in May, just like some of these are probably helpful if you want to have one little screenshot about, okay, let me tell you all the important things about this particular condition or this disorder. So tell me about your patient comes in, you suspect a kidney stone. What kind of problems is he going to have? Severe pain, renal colic is what we'll call that. What else? Okay, oliguria or anuria not producing. What's in between those two anyways? Oliguria is less than 400. Anuria is less than 50, 24 hours. So no hardly any urine output. Severe pain. What else? Hematuria. Frequency perhaps. Nausea, vomiting, headache, stuff that goes with severe pain. Right? And what's the condition called when he's retaining urine? Hydronephrosis. You may see that, right? So he comes in. What's your treatment plan? We're going to go from least invasive to more invasive. What's one of your priorities? Pain control. And what could be maybe, I don't know if I remember this, but sometimes if it's the first step is starting an IV. I'm going to run a bunch of fluids in there and I hope to get your stones run all the way through and irrigated out of there. Right? So you tried, you got a pain control, you tried an IV, that didn't work. What's another piece? And what kind of medication do you use for that? Flomax. Right? So we're hopefully maybe relaxing your urinary muscles to get that stone to flow on through. Okay, what's the next, another treatment? And what is that called? Lithotripsy, what is that? Right, jacking from the outside, it's called ESWL. Okay, so that's, what's another treatment option? Scoping, what do we do for that? Okay, break it up, grab it, there you go. We can always put in a stent, right, to open up the vessels. We can always put in one of the otomies. What do we do for that? Cut them open and put the tool in and take it out, correct, where that is placed. And if we have urine that's retained in there, it's not outflowing, and he's got hydronephrosis big time, nephrostomy tube, and your job as a nurse is to monitor when that nephrostomy tube is in place. Drainage, color, consistency, odor, amounts, all that kind of stuff. Questions about kidney stones? There may be dietary considerations. If we evaluated the stone, we may have our dietary recommendations for you. Had what? Okay. Yep, I guess that's an option too. We can laser buffet, right? Yep. Yep, I guess that's a possibility. There's probably some kind of like this.
I can't get it on my computer. It's like I get an error. You had an error.
Okay. Okay. So, all right. Bladder cancer, #1 risk factor is tobacco use. Again, We talked about that earlier. Chemical exposure, including tobacco use. This is an important slide to know. This is an important slide to know. Sometimes we'll instill a live virus into the bladder, allow it some dwell time. Because you know it's a live virus, you're going to send that patient home, and you're going to tell that patient, you know what, for the next time period, at least 6 hours, you need to contain your urine. But your urine still has some live virus in it. And we don't want you sharing that with your family members, right? So a separate toilet, men sit down when you're urinating, we don't want anything splashing anywhere. Clean the bowl afterwards with some bleach, wash your clothes separately, no sexual contact for a few days. So the whole principle of what can I have to do to educate my patients so that live virus doesn't get accidentally given to someone else in this household is where your brain needs to go with that. So about 6 hours afterwards, this is a safety issue. You do need to know that. Thinking, okay, I got a live virus, I'm gonna make sure the patient doesn't go home and potentially get that live virus to someone else that's living with them. Questions about those patient instructions? So basically, just contain your urine for 6 hours, all the things that go with that. If you only have one toilet, perhaps everybody in your household needs to go somewhere else for the next 2 hours until we're past that time. Okay, urinary diversion devices. You will need to differentiate those. It doesn't matter, it matters, but it doesn't. Some of them are connected in different ways. You don't have to know that to that specific. But what you do need to know is, does it mean that I have to catheterize through a stoma to get the urine out, or will I wear a stoma bag that will drain the urine? Because you're going to need to do the education for your patient on this one. And that's got a really good synopsis of the lady that has it, and we'll come to it. And then we'll have her worry about that. No falling asleep like in the lights down.
When I talk to people who are at a position where I was prior to surgery, I tell them that it's not going to be nearly as difficult as they think. We all tend to think that the worst is going to happen, that we're going to be in incredible pain.
Don't have her. All right, anybody, yeah, who's the IO person here? Oh, so there's no. Because you're the expert on it.
I thought you would volunteer.
It'll get stuck. Yeah. So that's why you have to wait around for someone.
Yes.
Burns power plant. What is it? That's a box. Huh? Oh. William Burr, what is that? Oh, that's amazing.
Thank you.
talk to people who are at a position where I was prior to surgery, I tell them that it's not going to be nearly as difficult as they think it will be. We all tend to think that the worst is going to happen, that we're going to be in incredible pain, that everything that could go wrong will go wrong, and that doesn't happen. I chose an ileal conduit. There were a number of reasons why I chose the ileal conduit. Number one, I was not a candidate for a neobladder. Too much of my urethra would have to be removed for me to be able to control the flow of urine if I had a neobladder. The other choice was the Indiana pouch, an IP. I decided not to go with that one because you need to catheterize. You need to make sure that when you're catheterizing, everything is clean, if not sterile. And since I do these long bike rides, I'm frequently using the porta potties. And I think we all know that porta potties are not the cleanest place in the world. Also, when I'm running, I'm frequently running in the woods, and we'll have to stop and urinate in the woods. And I just couldn't imagine standing there and catheterizing a stoma in my stomach with an IP. And so therefore I chose the ileal conduit. And I have to say, I'm really, really glad that I did. It's absolutely no problem whatsoever. And it doesn't show. People are often worried about whether or not it's going to show. Well, it doesn't. I have on a pencil skirt today, and I wear skinny jeans. I wear spandex workout clothes. I wear bathing suits. I go snorkeling. So there's really no problem with an ileal conduit, or as we call it, the IC. I was in very good shape before I went into this because I had been training for a 200-mile bike ride, and it was at the end of training. So I was in the best possible shape that I could be before surgery, and that certainly worked in my favor because I think the better shape you're in when you start, the more quickly you'll recover, assuming there are no complications. The recovery process after surgery was really a need to rest. There was not a lot of pain. I was amazed at how little pain was involved. They handle pain very well in the hospitals. Usually I had the pain pump where I could give myself extra shots of pain medication if I needed it. But the truth was I really didn't need it. The nurses kept saying, use your pain pump. And I kept saying, I don't need the pain pump. So it wasn't anything like I thought it would be. It was much easier. The recovery at home, I think the biggest problem that I had was getting my bowels to work normally again. I think that one either will tend to having loose bowels or will tend towards constipation. I had either one or the other. I was never in the middle for a while, but I finally got that straightened out. That was my biggest problem. I just found that I needed a lot of rest. I couldn't do much without feeling very tired for a few weeks. So I would do what I can, and then I would rest. Then I would do some more and rest. So after about 4 weeks, I was feeling pretty normal. At 6 weeks, I got the go-ahead to go back and do whatever I wanted to do, except lifting heavy objects. And even to this day, I restrict anything that I lift to 25 pounds or less, because there's always a chance that you can get a hernia after this type of surgery. Short of lifting heavy weights, I would say there's nothing that I'm restricted from doing. At 8 weeks after my surgery, I was back on my bicycle. 8 months after my surgery, I did a 100-mile ride around Lake Tahoe. So I think that for me, recovery was fairly easy, and getting back to a normal life was very easy. I think there are some myths about the ileal conduit. One of the big things is that it's going to show under your clothes. It doesn't. I discovered that tummy control panties holds the pouch, which is what we call the bag, okay? Holds it in place very, very nicely. You don't need any special equipment. You just fold it up, tuck it in your panties, off you go. And the tummy control has enough firmness to it, stretchy firmness, that it holds it in place and keeps it flat so that you don't have a big bulge under your clothes. I think another thing that is a myth is that your stoma is this big gigantic thing. And that was something that I had nightmares about. I had visions of, this huge gigantic red thing in my stomach, and it's actually only 3/4 of an inch wide. So I think people get concerned that it's going to take up half their stomach and it's just going to be awful and ugly, and it really isn't. It really isn't. I've even had friends ask to see it, and I say, sure, you want to see it? Here you go. It's not a problem. I think the thing that probably surprised me most was when I read about the fact that they might remove the anterior wall, which is the front wall of the vagina. And when they do that, of course, you're left with a vagina that might be 2 inches long, and it would make intercourse rather difficult. So I think it's a very important thing that people talk with their doctor about that, as I did. And I was told by my doctor that they don't have to do that. It just seems to be part of the standard for a radical cystectomy in females. But a lot of doctors leave the vagina in place if they're able to do so, depending on where the tumor in the bladder is located. And my doctor, fortunately, left everything in place for me. And therefore, I can continue to have a normal sex life. If in fact he had removed it, then I probably would have sought out reconstruction at some point so that I could have a normal sex life. But many people don't do that. They just find other ways to be intimate with each other. Having the IC has not really affected intimacy with my husband. My husband's reasonably laid-back person, and we've spent 48 years together, well actually total of over 50 years together. So there's not too much that would bother us. He has absolutely no problem with my stoma. He has absolutely no problem having sex with me. At first I bought some little skirt things that you can put on that hold your stoma in place, and they have little lacy things on it so that it looks cute. But we soon discovered we really didn't need that either. So it has not affected my sex life whatsoever. I think it's important that a man and a woman have a discussion about this, and we did. And I wanted to make sure ahead of time that he would be okay with it. I said, if you wanna leave, honey, now's your chance. But he said, are you kidding me? So yeah, no, we have a very good relationship all around. My primary helper was my husband. He was Velcroed to me the whole time. Every appointment, virtually everything that I did, he was right by my side. The people who I could talk to were my girlfriends. And I think this is pretty common. Women know that the best people to talk to are your girlfriends. And my next door neighbor would come and drag me out of the house when I was having chemo and say, we're going for a walk. And we did, and we would walk 5 miles, 6, 7, 8 miles, and we would talk the whole time. And she was a very, very influential person in relieving stress. And I had some other friends too who, even though I didn't really feel like it, would insist that Mike and I come over for dinner. So I had a relatively small but very intense group of people who were making sure that I was going to get through this. I didn't participate in any support group prior to surgery. About 2 weeks before my surgery, when I was really starting to hit the panic button, I accidentally came across the Inspire Beacon website. And I got online, and that made all the difference in the world to me. All of a sudden, I had a group of people who had been through the same thing that I was about to go through. And one of the gals, Nancy, gave me her phone number. So I called her. I must have talked with her for a good 2 hours. And all of a sudden I realized that I could get through this and I could come out on the other side and resume my normal life. She made all the difference in the world to me. And as a result, I try to do the same thing for other people. I make myself available because talking to other people who've been through it just makes you realize that it's not as bad as you think it will be, because we all tend to imagine the worst. It's hard to come up with 1 or 2 words to describe my life, but I would have to say that my life is fulfilling, very fulfilling. I am surrounded by people who love and who I love, and I am able to do the things I enjoy doing. I'm able to help other people. I'm giving back. My life is very fulfilling.
I think she does a great job covering a lot of aspects of.
I think a lot of parents talk about it.
It absolutely does. She covered a lot of good aspects about support and care and feelings and all of that. Anybody have questions on that? So true or false, she had a stoma in place. True. How did she get her urine out?
Self-care.
Oh, yeah.
No, she didn't want self-care. She didn't want self-care. Oh.
Yeah, I get back my power. I would not be able to do surgery very well looking at a screen like this. Now it's back on the screen, but I'm not back on mine.
I want to look at the little lace thing that she had.
Let's see, thank you. I'm back to writing.
What was it? A lace underwear?
Questions about the ileal conduit? The neobladder is another device. The neobladder is, as it says, neo means new. So they put a new bladder in, and it makes the function of the normal bladder. The problem with the neobladder is the patient oftentimes doesn't have that brain messaging that you have got a bladder that's full of urine. So we teach the patient, first of all, with your neobladder, you may have to push to pee. That means like when you have to pee in a hurry, when you're buried down, to allow you to pee more urgently. That's maybe what they need to do. They also need to urinate by the clock, because their brain will not tell them that they've got a bladder that's full of urine. So you can't just go around for hours and hours and hours and not use the restroom, because you're going to have urinary infections, you're going to have bladder infections, stuff like that. So you literally, every 3 or 4 hours, you need to go in, sit down, push to pee, get your urine out. That's the instructions you need to give to this patient. Because their new bladder is not hooked up to your brain the way yours is. You know when you've got urine in there, you know when you need to go to the bathroom, and they don't. So that's the instruction that we need to go with them if they have a new bladder. This particular device, there is a stoma, but this patient has to self-cap through their stoma. So the patient in the video had an ileal conduit. She had a stoma. Her urine came out of the stoma and went into her bag, outside, external. This one has a stoma, but to get their urine out, they had to sell the cath through their stoma. So they put a catheter in through their stoma, they empty the urine out into a container, and they have to do that every 3 or 4 hours. So could you educate your patient on these different diversion devices if you needed to? This is the way yours is set up, this is the way yours is set up, this is the way yours is set up. And one size doesn't fit all. Sometimes sounds like she had a choice, sometimes you don't, and lots of things with that. Yes, they're all made a little bit, yes. Inside. It's not an external bag. This pouch is inside. That's why you need to put the catheter in your stoma
She didn't want that
to
one.
drain your urine out, like you're straight cathing a patient.
She said she
Your urine
likes
will
to
come out, you put it into a container, they'll take the
pumps
catheter
and
out.
stuff, and she didn't
4
want
hours
to
later, you
she
do the same
didn't
thing.
have to put it.
And that's what she said she didn't want to have happen, because she said she's outdoor, and so her stoma drains her urine out into her external bag.
She didn't
So she
have
had
to
the
stop
evening
it
one.
because she said it was like sterile technique and stuff, and she didn't want
Not
to deal with that.
necessarily, people don't. Sometimes they'll put a gauze or something on it loosely so it doesn't irritate if they got it up against their clothing or underwear or whatever it might be.
So Indiana use
Kind of like any other thing, if it's not irritating,
So
sometimes at night,
with the
or
Indiana
like
pouch and the
clothing
other
where they can,
Mhm.
leave it open to air. There's not a lot of farm this time around.
Yay.
Yay, hurry up. This one, we're a little concerned about your potassium levels. Okay, diuretics, as I already talked about, which ones spare potassium means it'll hang on to potassium, which ones waste potassium. Wasting means that you're gonna pee it out, your potassium's gonna go out with it. So given a potassium level, could you figure out which kind of diuretic you wanna give to your patient? So your potassium is low, you're gonna wanna give them one of the aldactones, is a more common one of that list. Your patient's potassium is high, you wanna give them something like furosemide or Umex. As you know from clinicals, whenever you give a patient diuretic, we always ask what is the potassium level. We wanna make sure your potassium level, you're not gonna make it too low or too high or whatever it might be. So absolutely this one, you have to make a decision on which diuretic you wanna give to your patient. Pyridium, as we already talked about with Jeopardy, will change your urine bright color, may permanently stain. And we talked about a little bit of other medication earlier, I think, but if you have that in your notes from earlier, there's not too much this time around. Who's got questions on the content?
Can you go back?
Sure, yeah. This one or,
This one is in it.
okay, this one? The thiazides are potassium wasting, means that it'll decrease the potassium. The loop diuretics such as Umex and furosemide are the more common ones that we have seen. Aldactone is primarily the most common one that we see with potassium sparing ones. Yes, after the break. We'll do that last. It won't open up until after class. 2 o'clock. Yes, that's why the dietary one won't open. Okay, anybody need to see any of those again? You can take a break.